We're ready to go, Dr. Riley.
All right, we will give it just a minute since we're not quite at noon, according to my clock, and give people chances to join us here. But it does look like we will have a quorum, so we'll just give 1 minute and then get going. All right, it is 12 on the dot. We will go ahead and call to order. Shelley, if you can do roll call, please.
Andrew Rice. Dan Spate. Dan, are you on the phone?
Yes, sorry, I was on mute. This is Dan.
Great. Franco Castromarin. Frank Walter. Frank, you're on mute. If you could unmute. Give me the high sign. Gail Redley.
Present.
Eve Godstinker. Jason Johnson.
Hey, Michael. Hey, Dr. Foster.
Hey, guys.
Hello. Hi. Dr. Foster, will we have Tiffany here? Or is she...
Who's talking, please?
I think there's some background, Dr. Foster's.
Is that you, Tiffany?
Mark Jason is absent. Eve is absent. Josh Gaither.
Present.
Julie Augenstein.
Present.
Kevin Foster.
Present.
All right. We have 4. Thank you.
All right. Thank you, everyone, for participation and attendance today. The attendance report is in your packet. Just a reminder, if you missed 2 or more consecutive meetings, the Bureau will reach out to you to ensure if you want to still be on the committee. Also, a couple of housekeeping items. Anything that is said as part of this meeting is part of the recording that is shared at the Bureau's website. This does include anything shared in the chat or on video as well. We have 2 current vacancies, one for a physician who specializes in severe acute head injury treatment or spinal cord care and has interest or expertise in EMS, along with EMS serving on the EMS Council for Western Region. I know we do have an applicant in for that one. We are still just waiting for that official appointee to go through. If your term is expiring in 2024, please go ahead and submit your reappointment packet if you're interested in continuing on the committee. If you have any questions about that, please feel free to reach out to Shelley and she can assist you as needed. Just brief summary on the naloxone leave behind program. A big thank you to all the agencies and medical directors supporting this program. We are just seeing those numbers increase significantly across the state. I think we have close to 2,500 EMTs and paramedics that have completed the training. We have, if I'm calling my data correctly, I believe about 1,200 kits that have gone out to EMS agencies and about 180 kits that have actually been given out to patients. So really starting to see this get out into the community. So thank you to everyone who is participating. If you are interested or interested in your agency participating in the program, please feel free to click on the link that's on the agenda that will take you to our website for that. Next up, there is a governor's proclamation. This is Trauma Awareness Month, EMS Services Week next week, and EMS for Children Day as well. You can see the really nice proclamation from the governor's office. You can see the data there when you look at response to stroke, STEMIs, cardiac arrest, traumatic injury, substance use disorder, and heat-related illnesses and emergencies. Truly, EMS is providing outstanding care across the state for these time-sensitive illness and injuries. And you can see the dates at the bottom of the proclamation there. So I just wanted to make sure we took some time to recognize all the great work that's being done across the state by both our EMS and trauma providers. For those of you that were not here for our last meeting for EMS Council, we had our awards for our EMCT of the year for the 4 regions. That was really nice and well attended. Really nice to see people come and participate with their families. And then during STAB at the 9 o'clock hour, we had our first time awardees for multiple trauma center awards. So that was a really nice program that we were able to implement this year as well. Just to put a little plug, we had one award we were not able to give out because we had no nominations, and this was for someone with expertise with pediatrics. So if you know someone, Julie, I'm looking at you, for next year, if we put this out, we really want to make sure we are recognizing our professors who are interested in helping our pediatric community as well. So I just want to put that out there. It was very nice awards for both of those groups. I will turn it over to Chief Rossier for the Bureau report next.
We have some slides, and I feel like most everyone has been in the room at this point for listening to this 3 times in a row. So we'll go quickly. Again, let's recognize that it's National Trauma Awareness Month and EMS Week and EMS for Children Day next week. We thank all of our clinicians and all of our MDC members. You guys are rock stars. We just appreciate you. Rulemaking updates. If you haven't heard us say, we will be sending out information via Gov delivery, so please stay tuned. We have our EMCT certification and training rules that are open. There's a draft online and a link in the slide deck that is being distributed to you if you would like to review. We also are undergoing a rulemaking to talk about interfacility transport reporting requirements. Again, we will keep you all informed on next steps when it comes to any public meetings or any public comment opportunities. A big one that this group cares about, and it might even be on the agenda, is the EMR and critical care scope of practice rulemaking. And so I don't know, Gail, if you would like to cover that now or later.
I'll cover that later. Thank you.
Okay, so you'll see this in your packet that will go out. And if you just advance ahead to our additional state and federal updates, we want to thank everyone that has participated in our strategic planning process, and more information to come if you have not been a participant in one of our surveys, focus groups, listening sessions, or the April 10th Strategic Planning Summit. You can go to the next slide, Shelley. We just want to thank you, and we will make sure that we are distributing the information that has been compiled to gather our needs assessment as well as our strategic plan priorities. We have finalized our county and regional profiles as part of our needs assessment, and those are available for review. We will come back to our committees in September with the strategic plan for the councils to be able to review and approve. And we look forward to working with the regions closely on these next steps as we finalize our plan for 2025 to 2030. So thank you all for your participation in that. Dr. Bradley, is there anything else in this slide deck that you would like to cover with this group?
I will just give a brief update because I think it is exciting regarding share. If we can go back a slide. So EMS Council did just approve, for those of you that maybe did not hear that and are joining us virtually, creating a data standard for cardiac arrest data to maintain PEEP status. So the plan for this would be to have that kind of go forward starting for the 2025 calendar year. But really excited to kind of have some ability to improve some of our cardiac arrest data regarding the SHARE program. So that was just approved by EMS Council. And we got your attendance, Eve. Thank you. And I think that's it.
Thank you very much.
Next for the standing committee reports, Dr. Augenstein for TEPI report.
Well, at the last TIPI meeting, we reviewed slides for the shared data elements for PEEP status, which was approved as amended. Christina Kupinoff presented a slide and info on wanting an umbrella data sharing agreement with all trauma level hospitals for data for research. There was some mixed interest there. Dr. Bradley gave background on wanting to capture fentanyl when possible for ASTR. Carissa Wilson shared it was an option in a pick list dropdown. Dr. Bradley and Botzel shared data visualization pages for off-road vehicle injuries and falls incidents, and then the peers HB 2609 reporting requirement info was shared, and as well as a document was posted for response times by urbanicity report information and guidance on the ARS and peers webpage. And it's under the tab education and tutorials. That's it.
Thank you. Next, Dr. Johnson is not here. Not to put you on the spot, Amber, but did you want to give a quick update for education?
Education committee updates. So we approved the updates to the sepsis, and that was the updated one. We approved a fall training for EMS that went up on the website, and also approved one for Alzheimer's education. That link went up on the website as well. I thought there was one more. I think that's it.
QI stuff,
Which one?
the QI stuff from Josh.
Oh, yeah, and then we had the QI dashboards that went up, the toolkits as well, were approved by the committee.
Thank you. Next, Dr. Gaither.
PMD met March 21st, and again on the 1st of this month. For the March meeting, the minutes were reviewed and approved. There was a recap of the special meeting regarding EMR and critical care paramedics and draft rules. We prepared for the next meeting. And then there was a presentation on thoracotomies as a special training required skills for paramedics, as we've discussed previously. That was tabled for a point of order. There was a special meeting of PMD along with this group just a few weeks ago. We, at that special meeting, discussed multiple additions to the EMR and paramedic scope of practice, medication tables, which that was it. All right. I think I made it through. Sorry.
Thank you. All right. Next, Adam for PACES update.
Hi, everyone. PACES last met on March 21st, where Jordana Carpenter was voted as a vice chair. Chris Gilbert became the pre-hospital coordinator for us. Aubriana gave EMSC updates regarding the pre-hospital pediatric recognition project, as well as the National Pediatric Readiness Assessment. This assessment's a pre-hospital assessment of EMS agencies' readiness and ability to take care of pediatrics. So it's a great tool to find out where your EMS agency falls in terms of pediatric preparedness. I will share the link for that assessment in the chat, and our next PACES meeting is on July 18th.
Thank you. Next for discussion and action items, if I can get a motion to discuss, amend, and approve the meeting minutes from January 18th. All right, thank you. Any recommended amendments? Hearing none. Any opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
Next, if I can get a motion to discuss and amend and approve the meeting minutes from May 1st.
So moved.
All right, first and a second, thank you. Any recommended amendments to this one? Hearing none. Any opposed? Any abstentions? All those in favor say aye.
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 Next, I'm going to have Shelley bring up the scope of practice. So first, a big thank you to everyone who participated in our almost 4-hour marathon of reviewing scope of practice and drug tables. So I think, did get to a really good endpoint with scope of practice. So we have this here. The next step with this process, we are just waiting for this to officially get posted for public comment. That will get posted likely for 2 weeks, similar to our last scope of practice, and then hopefully get approved at that point. The go live for this will be January 1st. Part of the reason for trying to get this done is, number one, the reason we don't want to go back and forth between PMD and MBC is the loss of institutional knowledge if we wait too long about why we made the decisions. But also we want to give training programs the opportunity to really train and prepare for the scope of practice. And so we figured once this is approved, then the training programs can really utilize this to help kind of build their training. So we didn't want to wait till January when people can start implementing EMRs and critical care endorsement to be able to follow this. So this is available. I'm hoping we should hear by the end of this week when it's posted, and we will make sure that that gets out to everyone so you guys can see that. But this is the final work of all of your hard work. That is the status of that.
This official one will be posted in the minutes. Or no, so we gotta wait for it to be approved.
Yeah, we're pending final rulemaking steps, so public comment will come next.
But it will be posted to for public comment.
Ruth Ann.
Yes, Ruth,
Yeah.
so Ruth Ann will post that for public comment, so that it will be officially available.
Yeah.
Yes.
Ruth Ann's version shows the old version with strikeouts and yellow highlight.
Perfect. As long as I just want to make sure there's something for people to look at and they
Yes.
have questions somewhere.
Yes.
So in the public comment version.
Yeah, the public comment version will have kind of the edited version. So this is just like a clean version for this committee to see.
Got it.
But yes, the public comment version has the typical strikeout highlights and addition marks in there.
Is that hers? Hers, mine.
So just want to give an update on that. And then the EMS drug table one, we did have quite a bit of discussion about the drug tables. Just for a reminder for those of you who maybe weren't able to participate or just kind of the next steps with the process. We, I think, got to a pretty good place with table one. That was an easier thing to do because really with table one, it was essentially making sure that a critical care endorsed paramedic can do everything that's in the paramedic column. That makes sense. With EMR, I believe we added on naloxone. I don't think if we added on anything after the back and forth, but we are going to try to package those all together for approval. That leads a little bit into line E, which is kind of what to do best for the drug tables, because we had a lot of discussion back and forth with, I think, some good discussion of how best to add a critical care kind of drugs with, you know, with real recognizing that some critical care units may be responding to both a 911 call and an interfacility call. And so if we put a medication just on table one or just on table three, can they use that in both settings when they may be able to respond to both types of calls? So what we're trying to figure out what is going to be the cleanest way to do this. There was quite a bit of conversation of, you know, how broad do you get with medications? Do we do categories of medications like beta blockers? There isn't a consistent standard. I just came back from NSEMSO last night. Many states do have a critical care process, but many states are really just starting this. So I actually think we're at a pretty good place. But different states have different rules in terms of how the medication tables are. So I wanted to get the thoughts from this committee now maybe a little bit fresher than we were 3 hours and 45 minutes into that of how do we, what do you think the best way to propose to PMD in July, which would then come back to this committee in September, some proposed drug tables, because it would be nice to get those approved and kind of ready all to go live for that January 1st start date. Do we think it's better to create like a table 4, which would be a critical care paramedic for any setting? I think that might be the cleanest, but do people feel like that would create other complications? So I'll kind of start off with that.
I'll make a comment. I think that this, we may create some efficiencies by dovetailing this into some of the hospital-based non-critical care paramedic conversations and their medications. Because it's several of my stakeholders keep bringing up some, you know, nuances that don't make a lot of sense in terms of, you know, intravenous opioids, but not able to give an oral opioid. Over-the-counter NSAID, but not something like an intravenous NSAID, and some of those areas as well. And so, while we tackle that tough question, I would also ask the group to take that into consideration as well at the same time. Part of the solution there is by looking at the ability to reclassify medications by class rather than specific generic names. For example, NSAIDs, opioids, like we've done for antibiotics, for example.
So just want to kind of get a feel from the group in terms of, Shelley, your hand is up.
It is, I just wanted to revisit table 1. You guys
Pardon?
wanted to revisit table 1. The expectation of when they could see it would be after January 1. Is that correct?
No, once we have to get the other ones finalized, so it would all be together.
Okay,
So the drug tables go from MDC to the director?
so we're waiting for the others.
Yes.
Thanks.
So once MDC finalizes them, we just don't want to kind of put out something since there was really, we had a lot of back and forth conversation with table 3 and 4. I think table 1's at kind of a finished state, but rather than sending just one drug table up to the director's office for approval, let's hopefully get this as kind of a package of this is our completed set of drug tables for the director to sign and then publish.
Okay.
That's a maybe silly question, but it may help with the discussion. When we look at, I'm gonna mess up the table numbers, but table one has all of the required drugs for ambulances, right? That table is what goes in a drug box for a 911 call.
Yes.
The materials in table, I can't remember the number, the interfacility transport drug list.
Right.
Are drugs that I think, and correct me if I'm wrong, we envision being started at a hospital, not necessarily carried on an ambulance. Is that right?
So that's what we kind of developed 3A and 3B. So 3A is the interfacility classic started hospital A. This unit's going to take it to hospital B.
Mhm.
Then we also, when we were asked to kind of create a for hospital use, that's where we came to the 3B. So we're kind of getting into this time frame where it's gotten pretty complex. And so looking to see how best to figure out how to then layer on a critical care drug table on top of that, knowing that they could be doing both interfacility and 911 response in the same shift.
I have a question about that then. So would there be any consideration of combining medications that are not primarily started by paramedics, right? So your in-hospital and your interfacility are kind of the same thing, right? Where you have a whole list of medications that aren't started by medics, but can be continued in one of these various settings. I think maybe the hospital one, there's maybe a little bit difference in that, but they're still not giving medications in the hospital that aren't ordered by a physician. They're not making the decision to
Correct.
give an opioid. And same in the interfacility transport situation. They're not, you know what I mean? They're not making the decision necessarily to start up, outside of something like maybe initiating a pressor or initiating, I mean, there's some things I think certainly they could initiate, but it seems like we have two separate lists of kind of the same type of drugs.
That's part of the story, really what I know Dr. Walter has his hands up, so I'll make it brief and then turn it over to Frank. Really, in my mind, what we're making recommendations on is what should be the drugs in a critical care drug box a paramedic is carrying to start themselves. That seems practical, whether it's functional, just the level.
Presumably they'd be giving a lot of what they're doing is interfacility transports.
Right.
So, yeah.
Frank?
Yes, and sorry, I was on shift the day these were discussed. But if a paramedic is going to be starting, say, a beta blocker, I knew that came up as a potential, I just spoke with others afterwards, as potential hypertensive treatment. I would suggest avoiding non-cardioselective beta blockers to be initiated by medics in the field, say for a hypertensive crisis, something like labetalol that is non-cardioselective. And I put in the Daily Med, from National Library of Medicine, National Institute of Health link there. And the reason for my concern is that non-cardioselective beta blockers, such as labetalol and others, are contraindicated. It's not just a relative contraindication. If you go to that link and look at under number 4, contraindications, bronchial asthma and obstructive airway disease, which are quite common. So just to keep folks out of trouble, that would be my suggestion if considering initiating beta blockers by medics in the field and not having something that was started at a hospital that already has been shown to not cause a problem for a patient at the hospital in an interfacility transport. Is that clear? Any questions on that?
This is Dan. My concerns extend significantly farther than just this one example. I think Amber's insight is an overarching one, that it's one thing to be continuing something where a physician/nursing team has started a patient and now you're going to continue it, and all of the setups, the drug mixing, all of those things are basically in the bag. There's plenty of time to re-clarify, to ask questions, to if it's a drug that the paramedic hasn't used for the last year and a half. They can ask questions. The idea in the 911 setting of starting vasoactive drugs across a whole series of potential even lethal complications. I think it's a different world. Starting it in the field, and if our share and ethic information are representative of Arizona, the something like 90% of patient transports, at least in TBI and cardiac arrest, the transport interval is less than 15 minutes in 90% of them. So the idea of, well, what if they need to start it because it's going to be a long transport and the patient, quote, really needs it, in the opinion of the medic and or the medic and online medical direction. The numbers then get incredibly small, and the usage, the starting of the vasoactive drugs by an individual paramedic themselves without anyone else involved, it becomes probably a very rare event. And we know when the use of these drugs is rare, the risk of complications is probably far higher. So I have a general concern with this, and I'm interested whether others share that concern.
I see a couple hands. We'll go to Dr. Cooper and then back to Dr. Walter. Dr. Cooper, you are on mute still if you're trying to speak.
Trying to.
We can hear you now. Go
Oh,
ahead.
perfect. Thanks. No, I do agree with Dan, and the way the system seems to have been set up, these critical care paramedics would be able to practice in any of the three environments, right? The field 911 responses, the interfacility transports, and in a hospital setting. And mirroring some of the things we did in the past to maybe address some of those concerns was that discussion about, maintaining and monitoring a medication as opposed to initiating medication. And there is that difference in the interfacility transport when you have, a workup in a hospital that indicates the disease process and takes into account the other patient clinical factors versus the field response. So maybe kind of somehow, like I said, mirroring what we did in the past about when they can initiate medications versus just monitor ones that are started.
Thank you. Dr. Walter?
I echo Dan and Eric's concerns, especially, and again, I brought up specifically just, rather than approving large drug classes such as beta blockers, all beta blockers aren't created equal. So that's why I gave that example. But I think Dan's points and Eric's, I think, are both making similar points. I have the same concern about initiating critical care medications in the field. Thank you.
So one thing, Shelley, I was going to see if you could maybe pull up table 3 from our bullhorn. It'll come up easily from that. So the verbiage on our drug tables currently for table 3, table 3A is agents eligible for administration and monitoring. So that does not only mean that means someone could choose to start that medication if they had it in their drug box. So just to kind of clarify. And then 3B, which is the hospital use, which is again, agents eligible for administration and monitoring. So while the hospital setting, we recognize that this is going to have to occur typically because it's in a hospital under an order from a physician. When we came up with these lists originally, there was a little different group of settings, and that's why the lists weren't identical, recognizing that someone who's going to get a medication over a 12-hour shift in the hospital, potentially while they're holding their ICU admins, is very different from someone who's getting a 30 or 45-minute interfacility transport. Also recognizing that it's different if someone is doing an interfacility that's maybe from northern Arizona down to the central region, and now it's a couple-hour transport, and they recognize the patient has a change in status and they're going to be initiating on their own a medication. So now we will have a critical care paramedic, which, just to remind everyone, has a much higher level of training to be able to get that certification or endorsement. So while I think we have to remember these drug tables were for any paramedic, these paramedics may have no additional training outside of simply what the medical director gave for that medication. So to be a critical care endorsed paramedic, you have to have significant additional training to get that endorsement, based on what was recommended, and it's pending final rule writing process. But if those go through, so just to kind of put that reminder out there, there is a critical care endorsed paramedic is not the same as a paramedic that's just necessarily working in the field or in the hospital setting. Now, critical care endorsed paramedic could work in any of those three arenas. And so that is where it gets a little bit more complicated because there is a different level of training and expertise.
Yeah, Gail, this is Dan. Honestly, I don't think it's complicated about whether these drugs, especially drips, should be initiated outside of a place where diagnoses can be made, because we don't make diagnoses in the field. A place where a history can be taken, because some of these drugs with specific histories, Frank's only mentioned one, but with specific medical history and so forth, are relatively contraindicated, a whole bunch, and some absolutely contraindicated. The medic who hasn't initiated this themselves, that forgets and gives a beta blocker IV and a calcium channel blocker IV simultaneously, and the patient gets complete heart block. These kind of things, my concern isn't their level of training. My concern is the same concern, not from the decision-making point, but even technically from the, if somebody asked me to start a drip, one of these drips, I wouldn't do it, because the entire initiating process, it's time consuming, especially if you haven't done it frequently. And I think that the number of times that these will be indicated and started in the field will be very low. So if you then take that numerator of how many times they might be used appropriately and take the denominator across the state of all the critical care paramedics, I think per critical care paramedic, these decision-making processes initiating and the need for it, because it's, say, an hour transport, compared to getting to the hospital because you can be there in 15 minutes and you have other drugs that you can give IV push, etc. Some alternatives in those settings. I think I don't think personally that it's complicated, that we do want to bifurcate the continuation of these drugs. And if we need to change the rules in the table, I think now's the time to have a discussion.
So I'm going to go to Matt and then to Amber.
Thank you. I just wanted to point out that a lot of these medications already exist in the critical care environment. Most where critical care paramedics are working currently is in the flight environment primarily, where they're often partnered with a nurse. And any individual medical director obviously can approve a medication for a nurse to administer that doesn't really require state approval necessarily. So a lot of these medications are already being used in that critical environment. This is really just trying to create parity so the paramedic can assist in building those, caring for those patients.
Amber?
I think I would just sort of build up a little bit what Dan had said about the frequency of use. So I think that both him and Matt are sort of making a very similar point, that without knowing what the current protocols look like or that are generally in use, it's hard to make decisions about what medications would create that parity or would help a paramedic operate in that setting. Some of these conversations that we spend a lot of time on may be totally moot when we find out that none of the agencies are using specific protocols for specific things. And I have not looked extensively at them. And so I find it hard to figure out what is helpful without knowing what they're actually doing or might need to do on a scene call situation. I think I'm much less concerned about the interfacility transport, but on a scene call, what types of things would they even have protocols that would allow them to do before we, get down these rabbit holes of classes of medications and that sort of thing. So I don't know if that's a possibility to maybe look at some of these things to help guide that discussion a little more. But
I mean, Matt did provide a list of several medications. Those were many of the ones we did talk about at that joint session. But in terms of accessing each individual agency's protocols, to kind of figure out what they're giving, I could see if Anne is able to pull a medication list, and see if we have, like, from AZ Peers data, like, from interfacility side, what's the frequency of medications that's not a table one? She's probably sitting there pretending to throttle me right now, because that's going to be very complex to do, because I know she's working on finalizing that normal medication list.
Yeah, I can try to do that. I can try to pull a medication list. I may need a little assistance with all the different drugs, but yes, I can.
But I think it would give us an idea of what's being used medication wise, but we have no way of knowing really outside
Right. I think that's what makes this very challenging, is that we spend a lot of time talking about 4 different beta blockers, and really they might not ever get used on a scene call.
Well, and one more thing from Dan, we often make expert, if you will, rulings and opinions as a committee, just because of our experience. But we also often have at least some evidence in favor, and strong evidence that the likelihood of harm is low. But in this kind of setting, I mean, you cannot find in the literature even case series of, this is our experience of paramedics in the field following protocols starting these drugs. So we're essentially at a near absence of any evidence in favor. We have all kinds of reasons, primarily in 2 pots. One, these drugs can really hurt people if they're done incorrectly, and the technical skills related to them are consequentially linked to the second issue, which is the probable rarity of by themselves potentially starting this and functionally making the decision. So I just think the first do no harm is personally overwhelming here, because we just don't have even I was an medical director for 20 years. So of course, a lot of these drugs with a paramedic nurse team were given, but the reality is essentially never, even with the nurses, even though the scope of practice for nurses is essentially infinite in the state of Arizona because of the Nurse Practice Act. They essentially never started on a scene call any of these kinds of drugs. So I think it's a bad idea for it to be started in the 911 setting.
And I think just to kind of dial back the conversation, because we're saying, we're referring to all drugs right now, right? We're not kind of saying a specific class. So as we're talking, what we really need to figure out today is what kind of drug table do we want to create? So we can't just say all drugs are bad to initiate in the critical care setting, because there might, from a critical care paramedic in the 911 setting. I will tell you that many states have antihypertensive medications in their drug boxes for normal 911 paramedic calls. So that is present in many states throughout, and it's in the NASEMSO model EMS clinical guidelines. There's a number of medications that we do not have approved in Arizona. So there is a big push because of maternal mortality nationally, looking at blood pressure management in the pre-hospital setting. That is something that is getting a lot of attention, looking at blood pressure management and Pitocin in that patient population. So I don't think, we're not looking to debate a certain drug or drug category today, but rather trying to figure out what is going to be the best process to put something forward, potentially, because we do need to create this set of tables to support this. Brian, did you still have a comment you wanted to make?
Yeah, but a different one now. I'm going to be gone in July. I'm going to be riding to Glacier National Park. So I think, part of the thing over that table 4 addition was to look at those drugs could be interfacility or field. I think that we should go back to table 3 and create on table 3 the critical care paramedic list on there. And then that way, if we want to come up with some classes of drugs like beta blockers that were started at the facility, have classes of drugs that way on there. And then if we want to continue looking at table 4 to have drugs on there that the critical care paramedic would be authorized to administer in the field, keep that separate from the other one. And then that way we can, I think, if people want to keep specific drugs on there versus classes. But based off of some of the conversation, it seems like if it started the facility, they've been assessed for whatever criteria is appropriate for that drug to have classes of drugs for the critical care paramedic on table 3A and define it that way.
And then I guess the next question is, do you think there should be a table 4 or no table 4?
So I'm hearing you say that a table 4 would still be useful to keep it to specific medications for a critical care paramedic.
No, I'm saying that if the desire were to continue with that, to keep table 4 only for that purpose, I'm not saying the problem is that when you put it on that table, it doesn't matter whether they're with a nurse or they're not with a nurse on a flight team. They're going to have the ability to administer the drug. So maybe it's not appropriate for critical care paramedics in the field, because I think some of those drugs that were on that list, I do see flight teams are administering on field calls. So that's not just on interfacility transports on there. I do see some of those coming in, and they were field calls, and they had those drugs initiated in the field. The question is keeping it safe for everybody, because that's who it's going to apply to, is everybody. And is it just better to let nurses administer those drugs so that we're not having to deal with it? So I'm not sure table 4 is necessarily appropriate, but I'm saying if we're going to continue down that line, to keep that more specific only for the things, and only look at those things that people decide are going to be appropriate for the field administration.
I think that would be appropriate as a concept, saying that, the interfacility list is a bit more broad, and table 4 is appropriate for specific things that we've outlined as things specifically we'd be comfortable with.
So then the other option then to simplify that, if we're going to keep the interfacility on table 3A and just expand that, would be to make table 1, just add drugs to that would only be approved for the critical care column.
How does that differ then from our tox medic box, that type of stuff?
I mean, if you remember, we've kind of really pared the toxic box down to
That's table 2.
We have very little on there anymore, but that would be something where that might be easier than kind of creating now a 4th table, is just to say, okay, if now we're just going to address interfacility on the interfacility table, and it's going to be classes in general because it is interfacility, then let's put this on table 1.
I would totally be in favor for that.
Agreed.
Just some comments in the chat.
I see Dr. Cooper, Adam Collin for critical care, see James Cunningham. The table 4 is there, but I think it's kind of a tricky piece with that in terms of how do we address the differences of, we will spend an hour on each drug if we try to create debating and likely not gain consensus. We might gain consensus of PMD and we'll get to MDC and it will not be consensus. And so just knowing that there's a time frame, I hope.
Going back to Dr. Rice's point, I think one of the stumbling blocks here is that we're debating a drug in isolation rather than a protocol in which we are selecting the best medication to treat that. And I'd be happy to take the whatever workload of developing some drafts of, here's the 5 critical care protocols that we would consider using antihypertensive in, right? And maybe we start with the T3Gs for preeclampsia and say, what would a critical care paramedic do to treat preeclampsia? That's a very easy evidence-based guideline treatment protocol. Same thing, we look at whatever it's going to be, STEMI, right? That's a very easy one. We probably know what to do, and it doesn't involve a critical care paramedic. We look at stroke. There's some evidence-based guidelines for that. Then we can do medication selection based on some evidence-based medicine rather than an individual practice style preference. Right.
So let the protocols drive the medication conversations.
The only problem with that, is once a medication is on the list, it doesn't matter what the protocol or guideline is. So that's,
Yeah, I think that's always gonna be a
that
limitation.
is, one of the things, so we could create that, but once medication is on there, even if we create this awesome guideline for preeclampsia, once that medication is on there, an individual medical director can approve it for any use, right?
But then at least it's on the table for a reason.
But the other option would be to look at what's in the SEMSO as other medications that are approved in the model EMS clinical guidelines that we don't currently have in ours, right? Because that's in a national standard. So if there's 5 medications that are in a national guideline set that we don't currently have in ours, maybe that's an easy 5 to consider adding to table 1 with a critical care endorsement.
Yeah, that would be an easy way to do it.
And I'm looking at it's May, and we need to have something approved and done. Hopefully, because if it's not done by PMD and MDC, if it goes back to PMD in November, then we then push into 2025. So just timeframe wise, I don't know that we would get protocols / guidelines approved and done to then create the medication list, but we could certainly cross-reference Ms. Semso's model EMS clinical guidelines, come up with a list of medications that are in there that are not currently in on our table 1.
Hey, Gail, this is Dan. You
Yes.
made a point perfectly by saying that once it's there, we may have a really good evidence-based guideline, but that does not mean that it will be used for those purposes and not used for other purposes, et cetera. So the reality is that that's correct. So one of the issues here is the functionality. Some of it is that I've intentionally not become an expert at these tables because the arcaneness would drive me. I'd want to kill myself. So to me, I'm not the expert in the formatting, but what I believe we should have is we should have a only by permitting it to be started in the 911 system. We should start with a short list where this committee talks through the potential benefits and the potential risks and starts adding those that way. And what I'm hearing a lot of concerns is about timing and urgency and format. And my concerns are far more fundamental than that, because these things don't come back once the horse has left the barn. So I still have the fundamental concern of an entire critical care paramedicine, which has developed wonderfully over the last 30 years, primarily in air medical, but sometimes in critical care ground transport, but is grounded in people who are doing this a lot with other people making the major decisions and working with other people who have far more training and so forth, and they get really good at it. So this doesn't per se have anything to do with the letters behind their name, but the reality is to then put it into the 911 system for rare usage for that purpose. I think safety should drive that, and not urgency, and not how many tables we have and that kind of thing. That's my fundamental concern.
I think Matt and then Frank.
I apologize. I didn't mean to raise my hand.
All right, thanks, Matt. Frank?
I agree with Dan, and there may be some things I don't understand about the urgency, but I agree, first do no harm. And I'll just give you an example, and I brought up the labetalol again just because things were shared with me regarding preeclampsia, eclampsia, that kind of treatment. And if you look in Up to Date, it says that you shouldn't use labetalol if somebody is taking asthma medications. But then when you go to the labetalol link in Up to Date, it says what I already said and sent from Daily Med, that a history of bronchial asthma. And again, this is all about the initiation of these medications in the field. So I'm not opposed to looking at those things that are on the SEMSO and having a vigorous analysis of the pros and cons, the risks and benefits. But again, any medications that can stop the heart suddenly and any combination. Dan also mentioned the combination of intravenous beta blockers and calcium channel blockers. And at least through the Poison Center, we get at least one or more deaths a year reported on that combination. So those are just my thoughts. And again, just looking at national guidelines, they may not even go into the nuances, because like I said, if you go to UpToDate, it says, okay, if they're on these meds, don't use it. Don't use labetalol if they're on asthma meds. But then when you go to the link, so it extends risk and may have minimal or no benefit, has been alluded to by many. So, and I'm just bringing those concerns up. Thank you.
Thank you. So I think we'll open to Matt, and then we do need to keep moving on the agenda. This is really just to kind of get some information. This is not an action item. So I'll take one last comment from Matt, and then we will move on.
So I was just going to say that if the state would like, I would be happy to reach out to Guardian Air and Classic and get their protocols and send ones that would have examples of some of these medications as part of the 911 primary response, if you would like, if you thought that was helpful.
Yes, that'd be great, Matt. Thank you.
And it would also be helpful to know what the context of the team is, or whether the paramedic is by themselves.
It would be
I
all
suspect for these drugs, it's always going to be with a nurse. So, but making sure we understand the context where that's being done. So, oh yeah, we do that. When that's a nurse paramedic team, that's a completely different team than a paramedic by themselves in the field.
Dr. Godsinker?
Thank you. And I know this is getting belabored. I do hear the point of nurse paramedic team. This is kind of the whole idea behind us making the critical care paramedic, right? A nurse has a set of skills, a paramedic has a set of skills, and progressing forward with critical paramedic is only going to make them better and sharper and better at what they're doing. I personally feel that we should look at these medications, put them forward, and then kind of to the question later, do we need a separate table about where and when they can be used? I'm happy to kind of support the team what feels is best, but I just want to echo that really is where the medical director then can step forward and say, hey, here's the medications going on. To the point when a medication is out, we can also take medications away. So if we find that, hey, medication is not working appropriately, as an individual, you can take it away, and then we can always bring it to the state level and work on taking it away as well. And if that's incorrect, I apologize, but as an individual for your own practice, you definitely can.
All right, so great discussion. I think this is part of what we needed to kind of have some of these fundamental discussions. We know which way to move this forward. So I think it is important that we had that. And just kind of for a point of clarification, as people think about this, we can't guarantee you with staffing that is not there is a shortage of nurses willing to work the pre-hospital setting for critical care transports specific to inner facility. That is a big part of the impetus of having a critical care endorsed paramedic. And this is nationally, there's many states that have had this for a long time. And pretty much every state that doesn't have this is either in the process, finishing, or getting ready to start adding critical care endorsement. And there are national standards. So I think recognizing that we cannot rely and assume that there's going to be a nurse on these units. It's just simply not unlikely to occur. I think this is going to be the expectation that this is going to be a critical care trained and endorsed paramedic who's going to be providing that care. So I will. And with that, I move to the next one, which is discuss timeline for EMR and critical care paramedic rulemaking update. Again, just a big thank you. Many of you participated in our kind of big another marathon session working on the education rules for certification, recertification, training center requirements for critical care paramedics and EMRs. That has gone through the second public comment period right now. And I think what is the next step for us with that, Rachel?
For specifically just the scope of practice or the entire package?
No, just the like education and training centers.
Yeah, we still need to post and go back out to public comment. I think something that most people don't know is the Bureau does not have our own rule writer. So we are reliant on a department rule writer. And we will check back in with them regularly and keep you all updated. As soon as we post a new draft, we will send out a notice through Gov Delivery. My best guess of when it will be completed, if we're talking about articles 2 through 4, separate from scope of practice. My best estimate would be right before January. So the goal is to get everything in play by January 1. Again, that's all dependent on GERC, but the last timeline was to be on track before the end of this year in preparation for January 1.
Thank you. And then lastly, for our discussion action items, if I could get a motion to discuss, amend, and approve updates to the TTTG relative to patient destination and thrombectomy capable centers.
So moved.
All right, we have a first and a second. I believe I saw Aaron Streeter on the line from AHA.
Yes, I am here. Can you hear me okay?
Yes, we sure can. Go ahead.
Okay, great. Well, good afternoon, members of the Medical Direction Committee. My name is Aaron Streeter, and I serve as the Arizona Government Relations Director for the American Heart Association, which also has the division of the American Stroke Association. We appreciate the Commission's attention to the topic of thrombectomy-capable stroke centers during your agenda item discussions, especially during American Stroke Month. By way of background, stroke care certification in Arizona, given by the American Heart Association, the Joint Commission, and other certifying organizations, is based on the type of stroke care provided by hospitals. There are 3 certification levels outlined in the Arizona's administrative code a hospital can be recognized as. So your level 1 designation is comprehensive stroke centers. Your level 2 is primary stroke center, and your level 3 is acute stroke ready hospitals. So level 1 being your most comprehensive type of care. However, recent developments have introduced a 4th certification level, which are called thrombectomy capable stroke centers, which is what we're discussing today. These hospitals specialize in endovascular procedures and post-procedural care. This would be positioned between comprehensive stroke center and primary stroke center. Thrombectomy capable stroke centers have expertise and tools necessary to perform mechanical thrombectomy, a minimally invasive surgical procedure to remove blood clots from arteries. Ultimately, we would like to work with the Medical Direction Commission to update the T3 guidelines and the administrative code through the rulemaking process to align with our current certification practices. We also have certification practices for heart attack facility designations, which are like our stroke center certifications discussing here. And we're more than happy to continue discussions with the Commission to update our guidelines and administrative code to reflect our current certification practices. By starting with this simple update, we can ensure that EMS have the necessary guidance to transport stroke patients to the most appropriate facilities, ultimately improving patient outcomes. And that is all I have. And thank you for allowing me to speak and bringing this up on an agenda item.
Shelley, if you can maybe click on the link to, we do have the current verbiage in our statewide guideline. So, and if you can scroll, I think a little bit down, you can see under right there, there's probably a good place for that. And so, Aaron, what are you envisioning or looking to potentially propose this committee consider?
Sure, yeah. So we would like to propose, so if you, I don't know if you have the ability to look up the administrative code, but in the administrative code under Title 9, Chapter 25 of EMS, there is a section, let me pull it up really quick. I apologize. Give me 1 second. Yeah, so under R925-602, there is a portion that says location. It's under B3D. It says location of emergency receiving facilities that are, and it lists the 3 different facility designations in which we can certify. I mean, it's missing the 4th one. So whether it's updating guidelines, going through the rulemaking process to adding just that simple line of thrombectomy capable stroke centers, just making that simple update through rulemaking, or both, preferably both. So if we're going to update the guidelines, I guess having somewhere that says recognizing the 4 different levels of this certification for stroke centers, And then going through rulemaking and adding just that one line of stroke or thrombectomy capable stroke centers, if that makes sense.
So the rule writing process would definitely be outside of the realm of this committee.
Sure.
We have the ability, and the Bureau doesn't have the ability to open those rules.
Sure.
In regards to the guideline, and I'll kind of open up because we do have good representation really from kind of the entire state and region on this committee in terms of the current verbiage is left relatively vague, understating that there's parts of the state that may only have a primary stroke center and not have any other level of stroke center.
Okay.
And so looking to see what the group's thoughts are in terms of, we did not on these, delineate types of stroke center to go to only because these are really statewide guidelines, but.
Okay.
Additionally, we haven't put like destination related guidance in these because every region tends to make their own regional destination guidelines that make sense for their region with their regional council. So I think it would be a little bit outside of what we would traditionally do. I don't think we have done that for things like STEMI in here, or I can't remember what our cardiac arrest one looks like, but I mean, I think it might be a little bit outside of the TTTG scope to put destination guidance, although I obviously agree with the concept of getting folks to where they should go. I'm not sure if the best place is the TTTGs or more at the regional council, regional destination guideline level. Those are my thoughts.
Okay, yeah, no, I mean, that sounds great. I mean, if it doesn't make sense to put in the T3 guidelines, I just really wanted the opportunity to, I guess, start the discussion, and I wasn't 100% sure where. So I guess starting with this commission to figuring out where we need to go in order to get what we want achieved done. And so if this isn't the place to start with the rulemaking process, we can look elsewhere. I guess part of it is ignorance on my end of not 100% understanding the rulemaking process. So here I am.
I think honestly, as Dr. Weiss mentioned, the regional councils are really, for the most part, who decide destination decisions.
Sure.
So regardless of what's in rule, the regional councils and the agency's medical directors are really who determines kind of any destination decisions. So if you're, to kind of look at where best to affect change and getting these patients to the right location, that might be a better start, a better place to actually accomplish that work. Because there are parts of the state that already have some of those, Dr. Gaither and Dr. Weiss, the region have some of those destination decisions in their guidelines. But, it's just simply because something's in rule does not change what EMS is going to see in the field, I guess. Sometimes, to figure out how best to accomplish the goal, even if that fourth layer is added into the rule itself for stroke destination decisions, that wouldn't necessarily change what happens in the pre-hospital environment. But I think at a regional level, there's 4 regions in the state, that might be a better opportunity to have some of the conversation.
All right, absolutely. So thank you for your assistance on that. I mean, that's about all I have unless there's any other questions.
Yes, we'll follow up and make sure you have the information and connect with the 4 regional councils.
That'd be great. Thank you so much. I really appreciate your time.
Yes, thank you. All right. Any agenda items to be considered for the next meeting? Anything people would like us to address? Yes.
Yeah, I actually just sent you a text. I just had something to clarify. I don't know if we need to add it to the agenda for next week, but we have paramedics working in our ED. We do have a lot of, like, for babies that are in pain or getting procedure, we do sucrose. I know glucose is in the table. Does sucrose do that need to be specifically added, or can sucrose fall under glucose? And then similarly, we have a lot of lacerations, obviously, and we put like numbing cream on in triage, like Let and lidocaine and Epi are in the tables, but not tetracaine. Same with like LMX, and didn't see any of the topical.
Consideration, and we can add that for PMD then, and so that'll go to PMD in July. So we would add sucrose and let and LMX and EMLA. Can you send me an email only because I don't know how to print my text messages? Yes, thank you. To PMD. And that's table 3B. All right. Call to the public. Yeah.
I've got a specific list from Banner here. If you guys would find any value in that too, I could send that out. Just take with you, and it's their medication list. You know, it came up in discussion, so I could send that out if we have any values. Shelley, I'll just-
As the chair of PMD, I think that we need to probably have a little bit more of a clear-cut way of handling these requests, because I'm in the same boat as you guys. I mean, at every quarterly meeting we have with our paramedics and our ED directors, there's always 1 to 5 different medications that make common sense, but there's got to be an easier way for us to kind of handle these things, because I'm sure it's not going to, I'm sure it's going to be a rolling process, especially since the hospital-based medic practice continues to kind of grow.
So it's something we could consider. Do we do like a once a year? Because we don't want to be in a position where we're going to be updating a drug table quarterly. And even an annual update can, if you're kind of considering, can be cumbersome from a perspective of trying to train or approve at a medical director level. So I think that is a good conversation piece. What I would say is, if there's recommendations and things we have, PMD will have a kind of a large chunk. We'll prioritize the work only because the critical care part is really, we have to get done for the rule writing process by the set deadline. But maybe we can kind of come up with a pretty good list of what people would like to see added to the table 3B, which is the hospital use list, for consideration. And, maybe say that we'll collect a list of things people want to consider, but that we're not going to do kind of a quarterly update of our drug tables. Well, I think that is a very, very good point. Thank you for bringing that up.
Really urgent.
Yes,
To that degree,
Yes.
but it's
important but not urgent.
yeah.
All right. Upcoming events. There are a number of upcoming events in the agenda. We did have one clarification that the Southwest Regional Trauma Conference has been moved to August. Our next meeting is September 19th at noon. Will be both in person and virtual. And we will have the proposed 2025 meeting schedule, I think probably by July or we will have it well in advance for you guys. So if I can get a motion to adjourn. All right. Thank you. Thank you.
I didn't ding my phone. I know it's.
Thank you. Good job.
That's a nice thing. I was like, where's my phone? I'm looking everywhere.